Thank you, doctor. Now we'll move on to the next session. That is sulfonylurea. Old is always gold. And what I want to say is that you might have so many drugs coming in the market, but sulfonylurea is a time-tested drug which we have been using since I entered diabetology. That is 90. If you're not able to control with anything, yes, you can add sulfonylurea. But only thing is you need brains to use sulfonylurea effectively and also judiciously. Start low and go slow. That's what I can say. We have wonderful sulfonylureas. Let us hear from this about the glucocentricity and the role of modern sulfonylurea glycoside in current diabetes management algorithm by none other than my good friend Dr. Ravindranath, who is President-elect of Tamil Nadu RSSDA Tamil Nadu. He is the consultant physician and diabetologist at Trinity Diabetes Specialty Center. And over to you, Dr. Ravi.
So, a warm good evening to everybody, and I thank the organizers for giving this opportunity, and thank the chairpersons also for a nice introduction, Dr. Bodharni, a good friend of mine. Yes. Now we know the sulfonylurea was long back, more than 60 years of experience with the sulfonylurea derivative, when it was found in 1936, when the sulfur-containing compound was found to be having some hypoglycemic effect, and they started doing a lot of innovations on this molecules. And in 1946, they found out that they proved that the hypoglycemic effect of the sulfonylurea, and in 1950, one by one they formulated the sulfonylurea group, starting from tolbutamide, chlorpropamide, and acetohexamide, and even the tolasemide. So many sulfonylurea of the first generations have come, and after that we had that other generations like glyphosate molecules. We got a glimepiride molecule, glyclazide molecule. So many sulfonylurea has come, and now which almost pretty well that sulfonylurea still stands good in all our treatment armamentarium. And if you say, if you analyze the number of prescriptions in India prescribing sulfonylurea, almost more than 64% of prescriptions carry sulfonylurea derivatives only. So now we will move on to the glucocentricity and the role of modern sulfonylurea glyclazide in current diabetes management algorithm. Yes. The glucocentricity refers to the traditional pharmacological approach of strictly targeting the HbA1c reduction to prevent the microvascular complications. The modern treatment guidelines now advocate the cardiorenal protection alongside the glucose control. So nowadays the trend is now changing from glucose centricity to the organ protection level. So, however, the robust glycemic control remains the foundation of preventing microvascular complications. Whatever may be said and done, you have to achieve the glycemic targeted level along with the organ protection agents also. So the practice of the endocrinology in India poses many challenges, but simultaneously offers unique opportunities. The population here is predisposed to diabetes complications and the lower body mass index, and we are prone for more inpatient and distinct environmental factors and genetic factors also. But the newer drugs like the SGLT2 and GLP-1 receptors are prioritized for patients with established cardiovascular disease or chronic kidney disease. Glyclazide remains a crucial pillar in diabetes management. The modern sulfonylurea, particularly the glycoside, are strategically utilized within this modern algorithm as highly effective and accessible and safe glucose lowering agent. So among the sulfonylurea, glycoside has got its own unique property of many things which I will be narrating in the next few slides. And in Indian phenotype, as the previous speakers also told, there are so many types of phenotypes in India. We've got an autoimmune phenotype, mild obesity phenotype, age-related phenotype, and insulin-related phenotypes, sex-related phenotypes, and so many types of phenotypes are prevailing, and each and every one they respond differently for different pharmacological agents. That Indian type 2 diabetes are unique. They are challenged to treat because 64% of their patients refuse to follow the diet. Pretty well. Whatever there is now, sir, how much you are taking? I am taking only this much, sir. They show this hand only. Always they show this much of hand. Immediately of any place of in India, any patients, how much you are eating? I think you are eating too much now. No, sir, I eat only this much. So they differ to how much they are taking. The food habits, they are hiding it a lot. Of course, the ICMR in-depth study has shown that the patients remaining in the above the therapeutic targeted level experience a lot of complications. The consequences of delayed intervention also has been well proven with a bad glycemic legacy effect driven. The early aggressive treatment, aggressive control of sugar is mandatory to avoid the metabolic complications and to have a good metabolic memory in our diabetes era. The causes of the death in patients with type 2 diabetes, inoperable, sudden cardiac death, heart failure, and other presumed cardiovascular deaths are much prone to the uncontrolled diabetic status. So the improved glycemic memory has got its own effect of reducing all the micro and macroscopic complications, which was proved in the UQPD study starting from that, and so many other guidelines studies also have proved beyond doubt that good glycemic control yields a good amount of reduction in the micro and macroscopic complications. The time to reach target HbA1c, number one, and then the long-term glycemic durability is number two, and the risk of diabetic complications. These two are interlinked to each other, and so early achievement within the 3 months of time of detection of type 2 diabetes is mandatory to have a very good effect on the cardio metabolic benefits. The ominous octet, pretty well nowadays. Previously, we had only a triumvirate approach, only having only 3 pathophysiological features about 20 years back. Now, we have got ominous octet of all these factors and multiple roles played by the GLP-1 receptor agonists and the gliptins and even SGLT inhibitors have come to the market, targeting on various ominous octet pathway. The metabolic fulcrum-based approach for type 2 diabetic patients and the use of sulfonylurea, you can see there are two edges of this thing. One is a maladaptive anabolism, where there's overweight and obesity, high blood pressure, dyslipidemia, predominantly insulin resistance. Those drugs with the GLP-1 receptor agonist and other things are much acting on this maladaptive anabolism. And you see the other end of the part is a predominant catabolism, where the patients are thin-built and the cachexic and the osmotic symptoms are more pronounced, and predominantly their insulin deficiency status, those responds to only the insulin and the secretagogue. So, in between these two things, the maladaptive anabolism and the predominant catabolism, sulfonylurea may be placed in the center of the fulcrum and can be used along with other OHs to the left side or the right side, whether to the maladaptive anabolism side or even the predominant catabolism side. Both the sides the sulfonylurea will definitely fit into, and it acts as a metabolic fulcrum-based approach in type 2 diabetic management. We see the cost effective. This is one of the things that all the guidelines say. One of the cheapest drugs, sulfonylurea, have a low drug acquisition cost compared with the other classes of the lowering agents, and its recommendations are driven by the cost alone. Ignores the well-established efficacy and safety profile of sulfonylurea. Because it is very less costly, the efficacy is ignored totally. The sulfonylurea glycoside ranked number one because it worked as well as other classes of glucose-lowering drugs, but cost is the least. See how glycoside is different from the other sulfonylurea derivatives. We know pretty well there are some receptors in the beta cells. We've got a sulfonylurea receptor 1 and 2 and 2A and 2B, and even the APAC2 systems also there. And this molecule is peculiar in that it has got an affinity vary with the different sulfonylurea subunits, and the glycoside is, specifically binds and reversibly act on the sulfonylurea receptor 1. It specifically binds only to sulfonylurea 1, not with the 2 or 2A or 2B or even the APAC2 system also. Specifically binds with sulfonylurea 1 receptor, and also one more point is important, that it's reversibly act on sulfonylurea 1 receptor and is the only sulfonylurea not binding to APAC, as I told you before. APAC is one of the stimulating factors of the insulin exocytosis very vigorously, which might confer the lower risk of hyperglycemia and the cardiac safety also. So the mechanism of action, as I told you, the WHO has included glycoside in their model list of essential medicines in 2013, motivated by the safety and data in the elderly population. So, based on the data that they have grabbed from the elderly populations, the WHO they have listed the glycoside molecule in their model list. So, one of the important aspects that we want to highlight about the glycoside is that current literature does not support the notion that sulfonylureas are harmful to beta cell mass and function. They say that they destroy the pancreatic beta cells, but of late, the newer studies have proved, on contrary to that statement, sulfonylureas appears to improve the beta cell secretory capacity when used early in the course of type 2 diabetes. It is not dictated for the long duration of diabetes, but in the early stage of the diabetes, it has got a definite role of improving the beta cell secretory capacity. And the impact of low dose glyclazide is one of the main factors. Just give a very small dose of glyclazide molecule, it has got a beautiful incretin effect. It was augmented by 20 mg of glyclazide alone, thereby increase the glucose time in range by 17.4% and reduce the glycemic variability. And glyclazide increase the beta cell sensitivity also by almost 46%. So advanced studies, pretty well that there are more than 8 out of 10 patients achieve the glycemic control, and 10% reduction in the primary endpoint also was very significant in advanced studies. And of course, even the renal parameters, if you look into it, there is a significant 20% regression from the microalbuminuria to the normal albuminuria. Not only microalbuminuria revert back to normal, even the macroalbuminuria patients are reverted back to normal albuminuria in the certain studies have shown in the advanced studies. And significant 46% reduction in the end stage kidney disease was seen in the advanced study. So cardiovascular and renal safety of the drug it has got a peculiar anti-atherosclerotic action also. It increases the adiponectin level, decreases the cytokines like interleukin 6 and even the TNF alpha levels, showing the anti-atherogenic action. So apart from the glycemic parameters, it has got all these pleiotropic effects which are beneficial for protection of the cardiovascular and renal parameters. The anti-thrombotic effect of glyclazide, even you see, it inhibits the ADP-induced platelet aggregation. It reduces even the plasminogen activity or inhibitor level, thereby exerting a very good action on the anti-thrombosis. So the cardiovascular marker, among the various sulfonylurea, they have listed all the sulfonylurea here from even the first generation, the second generation sulfonylurea, wherein the all-cause mortality and the cardiovascular mortality was much favorable with the glyclazide molecule than with any one of the sulfonylurea derivatives mentioned here, or both first generation, even the second generation. And there is a reduced incidence of macro and microcell complications in the advanced field, which was shown clearly that there is a 6% reduction for major macrocell complications and 14% reduction for major microcell complications, 21% reduction in the risk of nephropathy. And this is one of the studies they conducted, mortality and cardiovascular risk associated with the different insulin secretagogues compared with metformin in type 2 diabetes with or without a previous myocardial infarction. The patient, whether they have experienced an infarction or not, with the type 2 diabetes patient, various combinations were shown wherein this glyclazide molecule outstands with all the other sulfonylurea derivatives, and there is a proven efficiency and safety among all the sulfonylurea derivatives. And the glyclazide in renal impairment also was very much pronounced when compared with glimepiride molecule or even the glyphosate molecule. With we can see the active metabolites which are there with the glimepiride molecule, which is not there with the glyphosate in the glyclazide molecule. So the nephroprotective effect of the glyclazide postulated mechanism, we know pretty well, scavenging the reactive oxygen species and even the upregulation of the MnSOD and the NADPH oxidation suppression are main factors that contribute to the nephroprotection of the glyclazide molecule. Even in Ramadan period also, sub-analysis were done that shows that patients with undergoing the Ramadan fasting are well much managed with the glyclazide molecule, with the terms of a good reduction in the glycemic parameters, and there are chances of hyperglycemia is very much less, and they can go for a preference of this molecule during the Ramadan fasting time. And during this Ramadan fasting time, better if we give the higher dose in the night time and the lower dose in the morning time, or you can choose the sustained release preparation during the Ramadan period. And the low dose sulfonylurea in MODI is also one of the factors that we choose for the HNFA category of MODI, who are very respond to the sulfonylurea group of drugs, and especially this glyclazide molecule in MODI sectors. And the guidelines of safer study, South Asian Federation of Endocrine Society has recommended these drugs in that they strongly position the sulfonylureas as a cornerstone first-line therapy for managing the type 2 diabetes in South Asian context, because South Asian population, they have got an early insulin deficiency rather than the insulin resistance, and their safest study, their safest association, they strongly recommend the glycoside molecule for treating type 2 diabetic manner. The paradigms for managing type 2 diabetes, that reducing the diabetes-related complications, are based on the current consensus recommendations by the ADA and the EASD. You got a blood glucose levels, intensified blood glucose control, and we had to consider the medication with the additional benefits we had to choose. Where other considerations we can have it as a medication's availability and accessibility, affordability, harms, side effects, and personal preferences, adherence, and the clinical stage of the disease, whether the patient's on the short duration of diabetes or the long duration of diabetes, and diabetes control status, and presence of the complications like the cardiac and renal parameters had to be met. Then after that we can choose improved outcomes and reduced risk of premature mortality and microvascular complications. So the new glucose lowering drugs, no long-term auxiliaries are there. Even though the newer molecules have come, it has not proved for a very longer time. So they lack in the long-term randomized controlled trials. But the glycoside molecule sulfonylurea has got a long-term randomized controlled trial results have come, and we can much rely on this molecule for a better control of sugar levels. So this discussions. Since their introduction in the clinical practice in 1950, sulfonylureas have remained the mainstay of pharmacotherapy in the management of type 2 diabetes. And despite their well-established benefits, their place in therapy is inappropriately being overshadowed by the newer generations. Many of the clinical issues associated with the use of the sulfonylurea are agent-specific and do not pertain to the class as such. And of course, the ADA ESD guidelines based on the accumulated evidence from these UOTs now offer a clear roadmap for selecting the glucose-lowering medications while taking into account each patient's comorbid conditions as well as other clinical relevant issues like a weight gain or the hyperglycemic concern, older age, potential access for the cost and the personal preferences is very, very important. And the latest guidelines can help clinicians select the most appropriate medications at the most appropriate times for each patient, with the ultimate goal of optimizing the patient's health and the quality of life. Of course, in the summary, the guidelines have been updated as per emerging latest evidence, and glycemic control remains the primary concern, and treatment of patients is always individualized. And sulfonylureas still remain the mainstay of treatment in type 2 diabetes, and the newer sulfonylureas could be better option for patient-centric approach. And glyclazide is one of the widely recommended sulfonylurea, having low risk of hyperglycemia and weight gain with the proven cardiovascular and renal benefits. So, conclusion, the modern sulfonylurea, glimepiride, glyclazide are backed up by a large body of evidence, experience, and most importantly, outcome data, which supports their role in the managing the type 2 diabetic patients. And the patient-centered care and careful choice of sulfonylurea, appropriate dosage, timing of administration, and adequate patient counseling will ensure that deserving patients are not deprived of the advantage of this well-established class of anti-diabetic agents. So, among sulfonylurea, glyclazide is distinguished by its specific pharmacological structure and molecular properties. Number 2, protection of beta cells and with its antioxidant ring, and the glycemic control and durability, and the proven cardiovascular and renal benefits, and low hyperglycemic risk factors, and weight neutrality. And with its extensive clinical experience and strong efficacy and safety profile, glyclazide can be included in every step of diabetes treatment algorithm. So, our track is on 2026 at Madurai, Tamil Nadu. Please kindly block your dates on 8th and 9th August 2026. I welcome you all for the conference. Thank you.
Thank you. Thank you so much, Dr. Ravindra. It was a beautiful talk, and I would open the session for the audience. If there are any questions, we welcome the questions.
I just want to add one thing. As I said, when the patient is using unnecessarily, they go in for secondary failure like that. And if you start putting some other drugs like GLP-1 receptor analog or other SGLT2, all that, they regain their sensitivity, and in that case they can go for hypoglycemia. So you have to be very cautious in reducing the dose of sulfonylurea when you use it along with the drugs once they recover their insulin sensitivity.
Maximum dose of actually the therapeutic dose of they say 320 mg as per the textbook, but we prescribe commonly 160 mg of glyclazide maximum. Morning 80 mg, night 8 mg is the maximum. Actually 60 mg once daily only they are done in all the trials, and some of the trials they say 60 mg 2 tablets once daily they recommend for the stubborn diabetes patients.
thing is, though it is 320, if they cross the off maximal dose,
Yes.
again you need to know that the drug is not acting. So you need to
Yes.
stop with off
Okay.
maximal dose.
Any type of sulfonylurea, of the maximum doses, the actually achieve the 80% of the glycemic reduction, and rest of the 50% only 20% reduction. So no point in going to the maximum therapeutic dose. So 50% of the therapeutic dose is the optimal dose for the sulfonylurea derivatives. If they do not respond, probably we can add the third drug, or we can use insulin therapy. Let me play as per the textbook. Yes. As per the textbook, it is 4 to 8 mg.
8 milligrams can be used, but I think 4 milligrams is the
Maximum dose.
maximum.
Maximum
Same
dose.
thing.
Beyond that, we cannot use. The same thing, Gliclazide also, 10 mg maximum.
Thank you. If there are no further questions, we can close the session. Thank you, Dr. Ravindranath, once
Thank you.
again.
Thank you so much, sir.
Thank you so much.
You can be on the stage, sir.
For a photo together, sir. Yes. Do we have Dr. Kumar, sir?